Dear PG, we are going to start our master class today. Now I request Dr. Mrinal Kanti Rai, who is one of our course director, to introduce the chairperson and also very briefly the subject also. Mrinal Roy.
Thank you, Dr. Amol Banerjee, our main key person of this master program. So good morning to you all. I think this class was just will be a repetition because about 1.5 years back, the same class was taken by some other nephrologist, probably Dr. Pratik Das took this class. Anyway, this repetition is very, very important because it is a day-to-day clinical problem. And we all know the Arghya Majumdar is one of the leading neurologists of the city as well as in our country. So he will give definitely due justice to the subject. A brief introduction to the subject is that it's a common day-to-day clinical practice. Sometimes we become befuddled with certain problems, and also the patient does not come directly with a kidney problem, but they come with some other related issues. The problem in the some other system, maybe in the pulmonary, maybe in the liver, and ultimately land up with the features of acute kidney injury. Besides the real etiological aspects which are inherently involved in the process of pathogenesis in the acute kidney injury. This topic needs very important, monitoring the patients, because of the fact that some of the patients we can lose if we cannot manage this acute kidney injury in course of time. It's special reference to the different indication, especially if necessary dialysis in some situations, besides the usual therapeutic medical therapy. Now, with this brief introduction, I now take you upon to another very important facets of this introduction, that is the introduction of our learned chairperson. The chairperson is very much known to this forum because she is really an academician, a brilliant, an erudite, I should say, clinician, and actually an astute clinician insofar the nephrology is concerned. I was with her for a pretty long time in SSKM hospital. Her acumen in the subject itself has sometimes made me really grateful to her because I have learned many things from her. Now, to her credit, she is at present, she is the DM and DNB as well as the MD medicine basically, but after that she did a DM as well as the DNB in nephrology. Presently professor and head of the Department of Nephrology. Dr. Shen is the professor and head of the department as president in SSKM, Kolkata. She is joint director of Regional Organ and Tissue Transplantation Organization. She has published more than 50 papers in multiple journals, both in the national and international levels. She is a reviewer of multiple journals and a scientific committee member of ISN India, ISN East Zone, and member of ISN, ASN, ISN India. With these few words of introduction, I now hand over to our respected chairperson, Dr. Arpita Ray Chaudhuri, to introduce our speaker and to start the deliberations from our side. Thank you.
Thank you, sir, for your kind words of introduction. And one thing I must congratulate API that they are taking this very, very important subject again and again, because it has been identified as very important risk factor, which is preventable to a large extent, and a bad outcome is expected only if people fail to recognize it early. We had a OB25 0 by 2025 attempt from International Society of Nephrology, in which all of us contributed data, and where we found that community acquired AKI is an important cause of progression or new onset chronic kidney disease as well. As we find 40% of medicine department beds are being occupied by either CKD or AKI on CKD. Considering diabetic as an important admission cause, AKI on CKD is very, very important one to increase the admission rate. And early recognition, a large way preventable, and a pre-renal AKI cannot be may not progress to dialysis requiring 2. With this introduction to the subject, and I would love to introduce Dr. Arghya Majumdar, who is actually a very, very knowledgeable senior from his early days, an astute clinician and a teacher to us from his postgraduate days. We belong to the same institute, and now he's a well-known name in critical care nephrology as well as in general nephrology care as well. He is an absolute right choice to talk about acute kidney injury, and heading the critical care unit of nephrology part of critical care unit in Dhakuria AMRI. He has an UK training in both nephrology and critical care, and I think listening to him will be a real learning experience in next 1 hour. And I would request Arghya now to continue with his listening for next 1 hour.
Thank you, Orpita, for the kind introduction, and Dr. M.K. Roy. Now, I'll speak today about various aspects of acute kidney injury, which is important to all specialties of medicine, to all practicing physicians. Now, first, coming to the definition, how do we define AKI? Now, first, going back to the 1990s, we used to call it acute renal failure. Basically, it's an abrupt decrease in kidney function. But how do we define or delineate this abrupt decrease in kidney function? So we have various ways based on serum creatinine, or the other aspect is based on urine output. But there are fallacies of both. We know the fallacies of creatinine because in people with sarcopenia, poor muscle mass, or malnourished patients, creatinine rise will be delayed. In the patient after fluid resuscitation, creatinine can get diluted, etc. Also, we know the fallacies of urine output because we have the subset of patients with AKI with non-oliguric renal failure. So basically, Claudio Ronco, he did a survey in about 2000 in one of his conferences in Vicenza. And he was amazed to, and we all were amazed to see that there are 200 different definitions in the literature or AKI, or acute renal failure as it was known then. And therefore, the Acute Dialysis Quality Initiative, the AKI group of which Ronco was a pioneer as well, they decided to sit together and form a consensus definition of renal failure. And they came up with the rifle criteria, the risk, injury, failure, and end-stage renal disease. Now this, as you can see, has two arms. One is based on serum creatinine, either 1.5 times rise or GFR decrease more than 25%, 2 times rise will be called injury, or 3 times rise from the baseline would be called failure. And on the other hand, the urine output criteria of less than 0.5 ml per kg per hour for 6 hours, for 12 hours would be called injury. And if it's less than 0.3 ml per kg per hour for more than 24 hours or anuria, then we call it failure. And if this is persistent for more than 4 weeks, then we call it loss or progression to end-stage renal disease. Now, certain studies after this showed that 0.5 rise was too much, and even 0.3 increase in creatinine, there was a mortality difference between 0.3 and 0.5. So therefore came the AKI criteria, in where stage 1 was described at increase of 0.3 milligram or 150 to 200% of baseline of creatinine. And stage 2 was 2 to 3-fold, and stage 3 was more than 3-fold. And we had the urine output criteria. Now, combining these, the KDIGO, the kidney disease improving global outcomes, they came up with the staging of AKI, where stage 1 is 1.5 to 2 times increase of creatinine or urine output less than 0.5 ml per kg per hour for 6 to 12 hours. Stage 2 is 2 to 3 times increase, and stage 3 is more than 3 times increase. So this is a consensus used all over the world, and now we stage AKI in this way. Now, another question which to all of us clinicians is, how do we calculate the creatinine clearance of the GFR on our daily rounds? Because in ITU, we need to calculate the GFR, and according to that, we need to adjust the dosage of antibiotics, various medicines, and take important decisions. So most of the equations which we use, and is well known to all of you, is the Cockcroft-Gault or the MDRD, or now we have a CKD EPI equation. Now, we carried out, one of our DNB students carried out a study in our ITU, and this was published in IJCCM, in which we compared the Cockcroft-Gault and the MDRD formula with the 24-hour creatinine clearance. And it was quite surprising to see that the Cockcroft-Gault and MDRD formula, though they correlated well with the 24-hour creatinine clearance, but they overestimated the kidney function. You can see the creatinine clearance was 79, and the Cockcroft-Gault showed it to be 90, and MDRD showed it to be 85. So till now, we don't have a very good equation to predict the GFR on our daily rounds, and we use the CKD EPI equation now, and these are available in apps, but there are problems in assessing GFR, particularly in the critically ill patients. Now, the second problem in critically ill patients is that the GFR changes from hour to hour within the day. Now, suddenly during the day, a patient may have arrhythmia or an episode of severe hypotension, and this would cause a dip in GFR. So even short collections of creatinine clearance, say over 2 hours, people have tried 4 hours, 6 hours creatinine clearance estimation, and they may not predict. For the morning, it may predict a creatinine clearance of 60. In the evening, it may be 40. So therefore, people have come out with kinetic GFR calculation. So this is the complicated mathematical model, but it's now available as an app. And this kinetic GFR, it predicted the AKI more accurately than MDRD. As you can see, the area under the curve of 0.86 versus 0.64, and need for renal replacement therapy was also more accurately predicted. Area under the curve 0.9 versus 0.79. So at the moment, maybe this is what we have in our daily rounds in ITU to estimate the GFR. This is available as an app. Now, the nomenclature as it stands at the moment is, we call it AKI, which was named by the AKI group instead of acute renal failure, to make it more well known to the general population. If the duration of this is less than 7 days, now duration of cessation of function is more than about 3 months, then we call it acute kidney disease. And if it's more than 3 months, then we have to call it chronic kidney disease. And on the other hand, we have no kidney disease if the GFR is more than 60 and there is no proteinuria. And as you can see in this diagram, that there is an overlap. So AKI can progress to AKD, and AKD can progress to CKD. Again, as Dr. Orpita mentioned, there are many patients which we are seeing first time in the critically ill situation, but these patients may have already had background CKD. So we are probably dealing with the AKI on CKD, where the prognosis is poor. So this is the kind of nomenclature we have at the moment. Now, coming to the types of AKI, now we know that we have the pre-renal type, where there is decreased perfusion of the kidneys. We have the renal type, where is the involvement of the intrarenal structures, the glomeruli and nephrons, and the post-renal, where their pathology lies in the kidney tubules. Now, let us understand this a bit better by seeing a few cases. These are real-life cases which I have taken from my practice. First, we'll deal with case 1. So this was a 53-year-old lady with normal renal function a year ago. And she presented with worsening oliguria, frothy urine, and a swelling of ankles for about 3 weeks. She was breathless on minimal exertion, getting up from the bed, going to the toilet, and she had dry cough, but no hemoptysis. There was no fever, skin rash, joint swelling, or frank hematuria. She had been diagnosed as seronegative rheumatoid arthritis and had been put on chloroquine and NSAID since 1982, off and on, and she had no recent flare-ups. And besides, she had hypothyroidism and vitiligo. So on examination, she was quite pale. There was no lymphadenopathy. There was central volume overload, but no dependent edema. She was hypertensive and had the hypopigmentation due to vitiligo. There was no evidence of joint inflammation anywhere or of deformities, normal heart sounds, and bibasal crepes. When the labs came back, we saw that she had advanced renal failure, urea 127, creatinine 8.3. The creatinine clearance was estimated 3.4 ml per minute. Microscopic hematuria, more than 200 RBCs per high power field, proteinuria of 3.5 grams, and a serum albumin of 2.6. There was sterile urine with granular casts, and the ultrasound showed echogenic but normal size kidneys. The labs showed severe anemia, so 5.9 grams hemoglobin, though this was normocytic normochromic in type, and ferritin of 333, quite adequate with a raised TIBC, normal B12 and folate, high ESR and CRP inflammatory markers were raised, a PTH of 200, so evidence of secondary hyperparathyroidism, and with normal ECG and echo. This is what the chest X-ray looked like. Now, would it be possible for students to interact? I'm not sure. What further investigations would we like to do? I think I'll proceed. So basically what we are dealing with is a pulmonary renal syndrome. So there is affection of advanced renal failure. Along with that, we have a bilateral pulmonary infiltrate. So first of all, she had a diagnosis with rheumatoid arthritis. Rheumatoid factor was negative. ANF and dsDNA was negative. C3 was raised and C4 was normal. So no evidence of complement consumption. P-ANCA was positive at 1 in 40, C-ANCA negative. And then finally, we got the anti-GBM antibody positive at 1 in 120. So we went ahead with the renal biopsy. After starting dialysis, stabilizing her with dialysis, there were 5 glomeruli, all showing diffuse proliferative GN with crescents. And there was marked sclerosis in most of the glomeruli with tubular atrophy and dilatation. And 1 glomeruli showed fibrinoid necrosis. And the immunofluorescence stain showed the characteristic linear deposit of IgG and IgA along the capillary membrane, as is expected in Goodpaster syndrome. So the diagnosis was Goodpaster syndrome, and we started the patient on bolus doses of methylprednisolone, 500 mg daily for 3 days, and then switched to prednisolone, and she received IV cyclophosphamide and plasmapheresis, 5 sessions initially daily and then alternate days. She received a replacement dose of IVIG of 10 grams and other supportive treatment with erythropoietin and iron supplement. She was maintained on hemodialysis 4 times 3 days a week. And once the anti-GBM titers were negative for 6 months, she was taken up for renal transplant. And subsequently, she is well. So this is one of the characteristic types of a renal cause of AKI. Now, when we talk about renal cause of AKI, there are various structures in the kidney, in the nephron. So there are the large renal vessels. So there may be thrombosis, atheroembolism, or dissection in the renal artery, thrombosis or compression of the renal vein. and involvement of the glomeruli and the renal microvasculature, which may be inflammatory, like in this patient, with causing a rapidly progressive glomerulonephritis, vasculation, or allograft rejection, as in transplants, vasospastic due to malignant hypertension, preeclamptic toxemia, or scleroderma, or hematologic. There may be microangiopathic hemolytic anemia. The disease may predominantly affect the tubules, with there may be a ischemia hypoperfusion injury. There may be injury due to antibiotics and poisons, or due to myoglobin or myeloma light chains, etc. There can be acute interstitial nephritis, which may be allergic secondary to antibiotics or NSAIDs, post-infectious or secondary to infiltrations like lymphoma or leukemia, and acute cellular rejection. So these are all the renal causes. Now we had a case of glomerulonephritis, so I'll just elaborate this a bit more. This may be associated with anti-GBM antibodies, as we saw in this patient with Goodbuster syndrome, associated with ANCA in Wegener's or Churg-Strauss. It may be associated with immune complex deposition, as in post-infectious GN or MPGN. It may be associated with normal complements, ANCA and anti-GBM, like IgA nephropathy or Hinox-Schwann nephritis, or associated with collapsing glomerulopathy due to HIV. And recently we have seen this with COVID-19 as well. So that was the first case, which showed us how a typical renal cause of AKI can present. Now coming to the second case. This was a 70-year-old lady who was operated electively for an incisional hernia in a nursing home. And during surgery, a jumbled up mass of jejunum was found adherent to the edges of the hernia. A resection anastomosis was done, and an anastomotic leak developed after 3 days. A relap was done, and a new perforation was found. Again, a resection anastomosis was done, and again this leaked after 3 to 4 days. Then she was shifted to the nursing home ICU, and later transferred to AMRI about 3 weeks after the initial presentation. Here she was tachycardic, blood pressure 150/54, oxygen saturation reasonably maintained, bibasal Krebs. Chest X-ray showed bilateral infiltrates, ECG and echo were normal. This was the chest X-ray. As you can see, bilateral infiltrates. Her abdomen was quite distended and bowel sounds were absent. So that was the most striking feature. Liver function was normal. Albumin was down already to 1.8. And on checking the renal profile, we saw that the urea was 38, creatinine 0.5. She was making adequate urine at that stage. She had a high white count and was anemic. And ABG showed predominantly respiratory acidosis. Lactate was normal. So subsequently, she was intubated and ventilated and taken to OT again. And exploratory lab was done. There were multiple adhesions and perforations, and end-to-side jejunal anastomosis was done, and proximal end of the distal loop was exteriorized. She was on broad-spectrum antibiotics, and the biopsy was suggested that it was Crohn's disease. She was started on mesalazine through the jejunostomy tube. Now on post-op day 1, she required massive fluid resuscitation, about 12 liters, to maintain adequate urine output. The abdomen remained distended, but she remained hypotensive and needed NORAD and dobutamine to maintain the blood pressure, and urine output started dropping. Now, if you can see in this chart, this is the bedside chart. You can see the urine output has gradually dropped and it has become nil later in the day. And initial resuscitation was with fluids and vasopressors. But however, you can see the blood pressure coming down through the day, and finally the blood pressure is down to 84/45. So severe hypotension. And then Finally, this had not been measured in the nursing home. Finally, we measured the intra-abdominal pressure. We found it to be very high at 25 millimeter mercury. And we called the surgeons, told them to open up all the stitches, but they were reluctant. They just took out 3 alternative stitches. The BP improved transiently. Vasopressors could be discontinued. She started making urine again, and the blood culture grew non-albicans candida. So that was septic shock along with the intra-abdominal hypertension. She was commenced on voriconazole. Post-op day 3, the condition again deteriorated, higher doses of NORAD, up to 1 mics per kg, and she was on pressure control ventilation with a PEEP of 5. You can see the pH. So in spite of, it was difficult to ventilate her and wash out the PCO2 to 120. Subsequently, pressure control was increased to 45, a tidal volume of 300 ml was achieved, vasopressin was started. Now the intra-abdominal pressure had gone up to 28. Finally, all the stitches were opened up. There was some improvement in hemodynamics and urine output, but on post-op day 5, the condition deteriorated, persistent oliguria. We started CRRT. Tracheostomy was done, but finally the patient developed septic shock, DIC, ARDS. No further surgical intervention was possible, said the surgeons, and she passed away. So where was the slip up? It was a long case, but it teaches us a lot of lessons. And the slip up was the delay in diagnosis of intra-abdominal hypertension and taking prompt action. Even when it was diagnosed, all the stitches were not removed. And that led to further buildup of pressure and irreversible multi-organ failure. Now, this is a form of, I'll explain in a bit, of pre-renal renal failure. Acute compartment syndrome is defined as symptomatic organ dysfunction that results from an increased intra-abdominal pressure and failure to recognize a rise above 12 millimeter when it is acute abdominal hypertension. And finally, when it crosses 20, we call it acute compartment syndrome, may lead to multi-organ failure and death. It's usually after post-trauma or multiple surgeries and tight surgical closures of the abdominal scar. It can happen after bowel obstructions, perforations, pancreatitis, and there is, after this, as in this patient, there is massive volume resuscitation, and because of the sepsis, patient has capillary leak, and there is fluid sequestration in the abdomen, further increasing the intra-abdominal pressure, decreased tissue perfusion, and lactic acidosis and multi-organ failure. Now, the important thing to realize is often the manifestations of this intra-abdominal hypertension is far-fetched, even right up to the CNS. It can even cause raised in intracranial pressure, and definitely in the kidneys due to pressure on the IVC and decreased preload and poor filling of the heart, decreased cardiac output. There is a pre-renal effect, pre-renal azotemia initially in the kidney, which finally progresses to ATN if it is not corrected rapidly. This is how, with a manometry, the intra-abdominal pressure can be measured by connecting with the Foley's catheter. I'm not going into the details, but this is the preventive strategy. And in such a patient where there are multiple leaks and perforations and re-explorations, the abdomen should not be closed. It should be closed only with a, a plastic vacuum pack, as is shown in the photograph. And a secondary suture should be done only later, after the patient has stabilized. And if the wound is closed, initially, once you recognize intra-abdominal hypertension, one must open up the stitches immediately. So this taught us a big lesson that even pre-renal or something we think as mild and reversible form of AKI can progress to ATN and severe stage 3 AKI if not corrected early. Usually, we get this prerenal AKI due to intravascular volume depletion. Now, this can be due to actual loss of blood, due to post-trauma, surgery, or GI losses, due to vomiting or diarrhea. In burns or hypothermia, there can be severe volume loss. There can be third space loss in acute pancreatitis, sometimes leading to abdominal compartment syndrome or crush syndrome. There can be states where there is no actual loss of fluid from the body, but there is relatively low amount of blood reaching the kidneys or the afferent arterioles. And this may be due to low cardiac output, due to cardiac failure, due to ARDS and high PEEP on ventilation, or severe vasodilatation, as we see in sepsis or liver failure or anaphylactic shock. We can have cases of renal vasoconstriction, as in ergotamine poisoning, when we use high doses of noradrenaline, and in hypercalcemia or use of calcineurin inhibitors. There can be impaired autoregulation when RAS inhibitors are on board, and this is a common scenario we face now with use of ARNI and RAS inhibitors, and also with SGLT2 inhibitors, and the patient gets diarrhea or volume depletion. And again, use of NSAIDs in hypoperfusion states. So coming to our third case, to see another aspect of AKI, this was a 74-year-old hypertensive gentleman who had low back pain, swelling of the ankles, and oliguria, marked central and peripheral volume overload. It's quite anemic with raised inflammatory markers. Urea was 41, creatinine 3.4. This serum total protein 7.2, albumin was 2.6, myeloma screen was negative. So we did the ultrasound scan, and as you can appreciate, there is bilateral hydronephrosis in the kidneys. So what would be the next step? We would do a CT scan to confirm that what is the cause of the hydronephrosis, so whether it's a stone or papilla or some other cause. And here you can see that there is a small irregular isodense soft tissue thickening noted around the aorta and IVC at the level of the lower pole of the kidney. See this soft tissue around the aorta. This is the aorta. There is atheromatous, there is calcification in the aorta, and there is soft tissue thickening around the aorta. It's encasing the aorta and the IVC. And subsequently, we did a malignancy screen because one has to rule out secondary malignant causes for this. This was normal. And the diagnosis was retroperitoneal fibrosis. So this was encasing both the ureters. So therefore, this is a cause of a post-renal type of renal failure. Now, what we did was we started him on hemodialysis, and he had bilateral DJ stenting, and he was started on immunosuppression. So prednisolone 1 milligram per kg per day and azathioprine. And subsequently, he did quite well. This is a follow-up CT scan after 6 months. You can see that there is clearing. There's hardly any soft tissue seen in front of the aorta, and the ureters were released and DJ stents were taken out. So this was also a reversible cause of renal failure if acted promptly. And this can be due to various types of ureteric obstruction. The ureteric obstruction can be either inside the lumen of the ureter, it can be in the wall of the ureter, or extra uretery. Intraluminal causes, there can be stones, but of course to cause renal failure, one has to get bilateral stones or blood clot. There can be sloughed renal papilla, as is seen often in diabetic kidney disease. Uric acid or sulfonamide crystals, fungal balls rarely. Intramural edema during ureteric surgery, and it may be extra ureteric, as in this case. There due to retroperitoneal fibrosis, or often it may be ligation of the ureters after pelvic surgery. There can be obstruction at the bladder neck, again due to stones or blood clots, or due to CA of prostate or cystitis mural edema, and extramural due to benign prostatic hypertrophy or prostatic carcinoma. Urethral obstruction may be due to congenital valves, as we see in children, or phimosis. So these are the various settings where various structures of the kidney are involved. And I hope with illustrative cases, you could understand it better. Now we'll come to the different settings in which we see AKI. And these settings are either in the community or in the hospital or in the intensive care unit. Now, in the community, I've just taken a few representative studies. This was published in AKI-CKD, community-acquired AKI in US, where pre-renal causes due to vomiting, poor intake, diarrhea was the predominant cause. And they were shown to be reversible. About 90% were reversible. And definitely the mortality was much better in the pre-renal causes than the renal causes. Now coming to the hospital acquired, this was again a study from USA, where volume depletion was seen as the major factor, congestive heart failure, and use of various drugs like aminoglycosides and radio contrast, septic shock, etc. was seen in hospital acquired AKI, where mortality is higher, about 35%. Now coming to AKI in ITU, this was a representative study from Australia. And you can see in ITU, as is prevalent in India, sepsis is the predominant cause. Even in Australia, it's 30%. In India, it's much higher in ITU, only followed a late second by cardiovascular surgery, 18%. So sepsis is something we have to be very careful about. And most of these patients, as you can see in the Australian study, were very sick. They were on ventilators, vasopressors, and on CRRT. However, there is a silver lining to this, and only 8% were dialysis dependent on the time of discharge. So they may die. There is a high mortality of about 50% in the best ITUs. Here, often multi-organ failure with AKI, the mortality is up to 70%. But if they get through this stormy phase, then the dialysis dependence is only about 8.3%. These are some old studies from India where, again, acute diarrheal illness from PGI was shown to be the predominant cause, followed by glomerulonephritis. And there were few cases of snake bites and poisoning. Now, a brief look at the pathophysiology. How is this acute tubular injury occurring? Now, you can see a predominant cause of this ischemia reperfusion injury to the tubules is intravascular volume depletion. Now, that may be either due to gastrointestinal or dermal losses, or due to hemorrhage, or massive vasodilatation due to shock. There can be large vessel renal vascular disease due to renal artery thrombosis or embolism, or renal artery stenosis. There can be small vessel renal disease like vasculitis or hemolytic uremic syndrome, malignant hypertension, scleroderma, sickle cell crisis, etc. Sepsis, very important, causing massive vasodilatation. Hepatorenal syndrome, where there is a mismatch of the vasodilators, vasoconstrictors, causing splanchnic vasodilatation, and again poor perfusion to the kidneys. That is another form of pre-renal renal failure. The use of medications like cyclosporine or tacrolimus, as in renal transplant, ACE inhibitors, ARBs, NSAIDs, radio contrast. So the various agents we use in daily life, and decreased effective intravascular volume. As I mentioned, these patients, there is no loss of fluid from the body, but in congestive heart failure due to low cardiac output, in cirrhosis or nephrotic syndrome due to low albumin. There is second spacing, the shift of fluid from the intravascular space to the interstitial compartment. And again, as we saw in abdominal compartment syndrome, where there is pressure on the IVC and decreased cardiac output. So all these lead to ischemic acute renal failure. Now, if we look at the cross section of the tubule, now what is happening there due to this pathophysiology? Now, this is the normal cross section of the tubule. These are the brush borders. These are the epithelial cells. And these are the red pegs are the integrins in which hold the basement membrane, the cells with the basement membrane. And the blue vesicles are the sodium potassium ATPase. They are the main active channels which are responsible for sodium and water absorption. Now, what happens due to the renal ischemia and reflow is persistent cell hypoxia. This causes a loss of the cell polarity, and there is redistribution of the sodium potassium ATPase from the apical to the basolateral membrane. Therefore, this impairs the solute and water transport. So the water does not get reabsorbed in the tubules. There is loss of the brush border and shedding of the brush border into the tubules, and which often clogs the tubules and forms intratubule casts. There is impaired cell and cell matrix adhesion and detachment of the cells. Again, these cells accumulate in the tubules and block the tubules. And there is impaired tight junction between the tubules and increased intratubular pressure, causing back leakage of filtrate. So these are the potential factors due to the ischemia, what is happening in the cross section of the tubules. And this is resulting in the apoptosis of the cells and their accumulation within the sloughed shells in the tubule. And of course, if we give supportive treatment and given time, a significant number of patients may regenerate the tubular cells and recover from AKI and again regain their normal polarity. So this is the pathophysiology. Now coming to what are the clinical manifestations of this happenings within the kidney. First of all, you know that organs crosstalk, and disease within the kidney has far-reaching effect on the brain. There may be, due to the uremic toxins, inflammatory mediators, there may be cerebral edema, even up to confusion, drowsiness, and seizures. In the heart, there is a renocardiac syndrome, and there will be fluid overload, and there may be arrhythmias due to hyperkalemia. In the intestine, now this is being highlighted a lot nowadays, this disruption of the normal microbiota. This can result in far-reaching effects. In the bone marrow, there may be cytopenia, systemic inflammation, acquired immunodeficiency. In liver, the effects of systemic inflammation. And again, very important, as we saw in one or two of the previous cases, that there is ARDS, lung injury, due to the developments within the kidney. And this ARDS can cause, one to need ventilation. So the far-reaching effects of the uremia. Now, what should be our approach once we have diagnosed AKI? I'll just give you a few practical points. First of all, our first point is, can this acute tubular necrosis or AKI be prevented? Because prevention is our strongest armamentarium in this regard. Second, is there a nephrotoxic insult besides sepsis? Sepsis we are dealing with supportive management and antibiotics, but we have to check whether we are giving any other nephrotoxic insult. Third, did the patient have CKD, background renal damage? From previous reports, also from ultrasound appearances, from the anemia, from the calcium phosphate reports, we can get some idea about this. can fluid, nutrition, and electrolyte balance be managed? Because these are the things which normally the kidney does. And if it's disease, then all this will be jeopardized. And finally, if we can't manage, does the patient need renal replacement therapy? So these are the issues which are before us when we see these cases. Now, first of all, coming to how do we diagnose, what is the causes of clinical, when we are referred a case in ITU, so what are the things we do? First, a detailed history is of course important, and we go through, I tell them to dig out and bring from home all their old hospital charts, and you see how many episodes of AKI and what has been the previous history. Did the patient have CKD before? And what are the drugs the patient has had? NSAIDs, ACE inhibitors, ARBs, ARNIs, etc., antibiotics. And often a review of the ITU chart I have found is very, very useful. It often shows that the urine output was fine. Suddenly in the middle of the night at 2 o'clock, patient developed an episode of atrial fibrillation. And subsequently, you can see the immediately next hour, the urine output has started dropping. Or some other complication like that. Patient has had a contrast CT, or some surgical intervention has been done, or a urinary catheter has been changed and immediately followed by hypotension. So sometimes the simple review of charts can give you these clues. Next, a detailed clinical examination is very important. Not going into the details, but head to foot examination is important, including ophthalmoscopy, and looking for rashes, presence of joint inflammation, evidence of vasculitis, various other lupus. It can give us a guide about what is the cause of the renal failure. And as I said, the review of the flow charts, the serial BPs, the serial urea creatinine, the various interventions and therapies, whether a new antibiotic has been started, amphotericin has been started the day before, things like that. Investigations, we do the baseline investigations. Along with it, very important to do a urine microscopy, the inflammatory markers, the hemolysis blood coagulation parameters, and very, very important when in the particular scenario, if we suspect from the history or clinical examination, then we must check the ANA, ANCA, anti-GBM, C3, C4, and in elderly patients, the serum immuno and protein electrophoresis. Ultrasound, KUB, is a very important tool, and it is, to us, it's like the stethoscope, because that helps to give us a lot of information, whether there is chronic kidney disease, whether there is pre-renal element, whether there is post-renal element. So all these can be, you can call it, this is our stethoscope, bedside ultrasound probe. Now, the diagnosis, like I said, clinical and along with the lab findings, urine microscopy is useful. If you see one of these muddy brown casts, often diagnostic of ATN. Now, urine biochemistry, this is much hyped. It is there in all the textbooks. Of course, if we get the patient in a very nascent stage, then of course, if there is pre-renal, if there is volume depletion and the afferent arteriole is seeing less fluid come into the kidney, then the urine osmolality will be high because the body will try to retain water. Whereas if there is tubular damage in oliguric ATN, the urine osmolality will be below 350. Again, the similar thing, because if there is low flow in the afferent arteriole, then renin, angiotensin, aldosterone mechanism is activated, and the aldosterone will retain the sodium. So in pre-renal cases, urine sodium will be low, whereas in oliguric ATN, I told you that there is disruption of the sodium-potassium ATPase, and the sodium cannot be retained. And one can also calculate the fraction excretion of sodium, which can differentiate it. But there are a lot of fallacies. These patients, by the time they come to ITU from the emergency, they would have received a bottle of normal saline, or they would have received a diuretic. And after that, you cannot interpret these cases. So if the patient has received diuretics or contrast media, if the patient has CKD, acute on chronic, or has previous glomerulonephritis, interstitial nephritis, or diabetic kidney, then these tests are not useful. Otherwise, in the patient in the nascent stage, one can utilize urine biochemistry. Now, very important, when do we do a renal biopsy? As we saw that we did that in the first case, usually we wait for 6 weeks because that's the time, average time with the ATN takes to resolve. And once there is satisfactory control of sepsis. However, if there are any red flags, like I mentioned, if there is a vasculitic rash, or there is evidence of diffuse alveolar hemorrhage, other things, or sinus, epistaxis, etc., indicating that there may be vasculitis. If there is feature suggestive of HUS-TTP or multiple myeloma, then we may think about a renal biopsy or lupus. And one thing is, all transplants with acute renal impairment, we still, though there are many alternative test non-invasive strategies, but we still go for the biopsy, which gives us a good picture about what is happening. Is it acute rejection or tacrolimus toxicity, etc. Now, another big development in the last 10 or 15 years has been the endeavor to find the holy grail, that is to identify a biomarker which will tell us whether the kidney is being affected. Just like in the heart, the TROP-I has revolutionized the management of acute MI, and we can pick up within 2 or 3 hours. We are looking for a biomarker which can pick up renal injury much earlier, because creatinine rise takes often more than 24 hours. So one of the first biomarkers which was described, this was in 2003, published in JSON, was NGAL. Now this is human neutrophil gelatinase associated lipocalin. It's released by all immune cells. This is one of the earliest and most robustly induced genes and proteins in the kidney after ischemic nephrotoxic insults, detectable soon after AKI. The first studies were done in CTVS surgery, because often in cardiothoracic surgery, where the point of injury to the kidneys, when the patient goes on bypass, that is the point where the injury was sustained. Where this is information we don't get in other cases of AKI, like sepsis, etc. We don't know the exact time of onset of sepsis. So after cardiothoracic surgery, NGAL was seen to rise tenfold within 2 to 6 hours of surgery. And the initial studies were too good to be true, area under the curve of 0.998 for 2-hour urine NGAL. So it seemed very, very promising. And this was further corroborated in mixed population in intensive care unit. But however, the very fact that NGAL is not released just by the renal tubular cells, but also by the immune cells. So in presence of sepsis and all, there is release of NGAL from the T cells and B cells, and therefore the it could not live up to the promise, and subsequently the renal injury biomarker, that is this metalloproteinase TIMP2 or insulin growth factor BP7. Currently, this is the most promising biomarker. I'll just explain how it works. As soon as the kidney tubule is stressed, it goes into growth arrest at G1. And these biomarkers, this metalloproteinase and the insulin-like growth factor is released from the cell, and we can check it in the urine. And it comes as a combined test, the TIMP, IGF, BP7 combined test, and point of care. I think soon we will be acquiring this test. And at the moment, this is very promising, because this gives us early information about injury of the tubular cell. Now coming to risk assessment. Now with the evolution of biomarkers, and this was a situation, and diagnosis called subclinical AKI, initially proposed by Claudio Ronco. Now we have a situation where there is no rise of NGAL and no rise of serum creatinine. So no AKI. there is a situation where the NGAL is raised, suggesting that there is some injury to the tubules, but serum creatinine is still stable. So this is a condition we can call subclinical AKI. That is the beginning of structural injury to the kidney. On the other hand, there can be a situation where the serum creatinine is raised, but the NGAL or cystatin C, the injury markers are totally normal. So this may be a functional AKI. So this pre-renal AKI where creatinine is raised, but there is no injury to the tubules yet. And of course, we have the fourth category where both NGAL and creatinine are raised, where we know that ATN has occurred or AKI. Now, this may be a way where we know how to reclassify AKI in a new way. And it is the area of subclinical AKI. This is where we need to intervene with our agents. And most of the trials in AKI have failed. These have succeeded in mice, but they have failed in human beings because I think we are giving the intervention too late when already the tubular cells are apoptosis. So if you can identify cells in subclinical AKI, maybe we can make a difference. Another thing which has evolved is the concept of renal angina. Just as in the heart, when blood flow is reduced, then there is angina due to injury, early injury of the cardiac muscles. Similarly, the concept of renal angina has developed, and this is the renal angina score which has been developed, and particularly this in the pediatric population. There are a lot of studies in the pediatric ICUs where this has been used. This is a scoring system in pediatric ICU. Moderate risk if the patient is in PICU already, high risk if there is bone marrow solid organ transplantation, 3 score, very high risk if ventilation inotropic, then the score is 5, and clinical injury signs of fluid overload. So you can allot these numbers and see how much at risk the patient is. This is a study published in KI reports, which shows validation of this renal angina index. And so I'm sure there will be studies in the adult population as well, and utilization of this at-risk population, because that is again the time to intervene. We identify the patient at risk. Now coming to the outcome, as Dr. Urpita mentioned, now we have realized the AKI may not be that benign and that not all AKIs recover. And if the AKI was very severe, if there was background chronic kidney disease, if the number of AKI episodes are multiple, and one important factor is if the proteinuria, if there is proteinuria and follow-up after 1 month, these are factors which indicate that this patient may progress from AKI to CKD, and this can have distant outcomes also on cardiovascular events as well. This is a cross-section of the kidney. As I said, after apoptosis, this is healthy recovery of the kidney, and this is what is called maladaptive repair. Now that is what decides which patient will go into CKD. After, there are cells, regenerative cells in the kidney. If there is maladaptive regeneration within the tubules, then that patient will go into the TGF-beta pathway fibrosis and CKD. And as you can see from this cartoon, that AKI stage 1 patients usually don't progress to AKD or CKD. AKI stage 2, some can progress to AKD. Whereas AKI stage 3 patients, a lot of them progress to acute kidney disease that is beyond 7 days, and a significant proportion progress to CKD. And if it is further advanced, they can progress to end-stage renal failure. And these biomarkers, various biomarkers like cystatin C, interleukin 18, KIM1, some can help us to identify increased risk. Some can help us to identify kidney injury, and some can help us to identify which ones will go to CKD. Some of the biomarkers can help to predict which one will go to CKD. Now coming to the management of AKI, basically, what we are trying to do is either prevent development of ATN if we are acting at this stage, limiting the extension of AKI if we are working at this stage, or treating established ATN or AKI if we are working at this stage, and accelerating regeneration if we are working at this stage. So according to this, we know what are the strategies to be adopted. Now the KDIGO has come out with some AKI care bundles, like we have the sepsis care bundles. There are some care bundles which we can follow in our daily rounds in the ITU and hospital, and ensure that that none of the patients are on nephrotoxic agents, ensure the volume status and the perfusion pressure, consider hemodynamic monitoring, regular check of creatinine urine output, avoid hyperglycemia, consider alternatives to radio contrast procedure, do a MRI instead of contrast CT if possible, non-invasive diagnostic workup, consider invasive diagnostic workup only when it is necessary, check for changes in drug dosing by daily calculation of EGFR, and consider kidney replacement therapy when it is needed. Avoid subclavian catheters because, as I said, some proportion of these patients will progress to CKD, and later on fistulas will be formed in the radial and brachial arteries. So subclavian catheter insertion, arteries and veins, so may jeopardize future development of fistulas. Now, from the care bundles, I'll just highlight a few things that what are the nephroprotective strategies in ITU. So first thing is to search for correct pre-renal and post-renal factors. I told you that adequately volume replaced or post-renal factors through USG. Now, coming to the pre-renal factors, this involves optimizing the cardiac output, the intravascular volume, and the mean arterial pressure. To review, this is easier said than done. I'll just come to this in a second. To review medications and avoid nephrotoxic insult, optimize the glycemic status. Very strict control, as was shown in the nice sugar study, caused episodes of hypoglycemia and increased mortality. So now the target of CBG should be about 140 to 180. Avoid intra-abdominal hypertension, as we saw in the case. Diuretics do not help in recovery or prevention of AKI. They should be used only for fluid overload. The question of renal dose dopamine, which does cause a bit of afferent arterial vasodilation, but does it help? I'll just come to this in a minute. So basically, when we are managing patients in ITU with other organ dysfunction, we have to pursue kidney-friendly strategies. That is, when, say, a patient is being ventilated, we must use the minimum required PEEP. High PEEP will cause decrease in kidney perfusion, etc. Now, another question commonly, often when we walk into ITU, we see that the noradrenaline infusion is going on high and the mean arterial pressure is maintained at 90 or so. Now, is this needed? Because we feel comfortable when we have a high mean arterial pressure. This elegant study published in Critical Care Medicine showed that comparing a mean arterial pressure of 65 versus 85, there was no difference in urine flow. There was no difference in serum creatinine rise of 65 versus 85. So now 65 millimeter mercury is taken as the optimal mean arterial pressure, unless there are two situations, unless the patient was previously hypertensive or the patient has abdominal compartment syndrome or high intra-abdominal pressure. When we need to mention a higher mean arterial pressure, because if we look at the renal perfusion, the abdominal perfusion pressure is mean arterial pressure minus intra-abdominal pressure. And so therefore, we may need to maintain a higher mean arterial pressure to maintain renal perfusion. And in these cases, often the autoregulation is lost, and whatever is the aortic pressure that will be directly transmitted to the kidney. Coming to the next issue, that is the patient volume depleted and does the patient need fluid? Now, this is a very difficult issue. Hemodynamic monitoring. Initially, we used invasive like a CVP catheter or a Swan-Ganz catheter, these have gone out of vogue. And now we are using more non-invasive methods like PICO or Vigilio monitoring. These can give us an idea about whether the patient needs fluid resuscitation. And like I said, ultrasound can become the bedside stethoscope for us. Monitoring of the IVC, the inferior vena cava, the compressibility and the respiratory variation, that is a bedside thing we are using every day now, and that is very useful in giving us a rough idea about the intravascular volume. Another thing utilized in operation theaters, particularly cardiothoracic OT, is transesophageal echocardiogram, and that gives a very good idea about the left ventricular end diastolic volume and pressure. And if that is maintained, then that helps to reduce development of AKI. Now, one issue is the central intravascular volume, and the second issue is volume responsiveness. So there are two different issues. Now, even with an ejection fraction of 25%, a patient may be volume responsive and may increase blood pressure on being given volume. We must not deprive a patient with dilated cardiomyopathy just because the ejection fraction is low if he has developed sepsis. Now, one safe way is a very, very simple test. It's a passive leg raising, because what happens in this patient with ejection fraction 25%, if we give 250 ml of normal saline and the patient goes into pulmonary edema and already has developed renal failure, then diuretics may not work and patient may go on to the ventilator. So what we can do is just raise the foot end of the patient by 45 degrees, and this infuses about 500 ml of blood from the capacitance vessels into the circulation. And if you see that the blood pressure has increased, then you can give him the fluid bolus. However, if the patient is going into pulmonary edema, all you have to do is drop the legs again, and the blood goes back to the legs, and the patient does not develop the persistent pulmonary edema. So I think that is a very useful thing which can be done even in districts and in small ITUs in nursing homes, and does not involve any expensive monitoring. Now, the patient is volume responsive in a very small window, and we have to resuscitate the volume within this window. On the other hand, there is a lot of literature now being published that after the first 24 hours of volume resuscitation, if we keep on giving volume to the patient, the development of cumulative balance ultimately causes worsening of renal function and mortality. Now, coming to what fluid for resuscitation, crystalloids are preferred. Hypertonic colloids may increase risk of AKI. Large volumes of normal saline can cause intrarenal vasoconstriction by hyperchloremic acidosis. Now, are balanced fluids better? We'll see that in a second. Saline and albumin are similar. Of course, here the SAFE study was done with 4% albumin as resuscitation fluid. We do not have that available in our country. And 20% albumin has a role only in severely hypoalbuminic patients to start with organ edema. There is no role of hydroxyethyl starch, as was shown by VICEP study and many other studies in resuscitation of septic patients. Now, coming to balanced solutions, this is the latest study which was published by the Australia-New Zealand group, and they showed that that use of balanced solution like plasma-lite versus normal saline, there was no difference in the mortality, there was no difference in the development of AKI or increase of creatinine. And if we look at the forest plot, we can see again in various groups, like subgroups like sepsis, after surgery, and with Apache score, we have similar results. There may be a tendency with higher Apache scores towards balanced fluid. I will just say that at the moment we have to individualize the patient. Whenever the patient needs large volumes of fluid, 3 or 4 liters, like post-traumatic resuscitation or sepsis, then we should use balanced solution in a ratio, say 3:1, along with normal saline. Coming to renal dose dopamine, there were 61 trials, multiple patients. It shows that dopamine is not useful. And in fact, in this editorial in Chest in 2003, Holmes called it bad medicine. So we should not use renal dose dopamine in ITU. Norepinephrine is the drug of choice when used as a vasopressor. It can increase renal perfusion if the mean arterial pressure is increased without a decrease in cardiac output. Vasopressin may be used as a noradrenaline sparing agent. So if we see that a norepinephrine is being required more than 0.6 mics per kg, one can add arginine vasopressin, because vasopressin does not have an action on the afferent arteriole. It helps to constrict the efferent arteriole, therefore increases GFR. And above 0.6, norepinephrine may have an action of constricting the efferent arteriole and causing renal hypoperfusion. Loop diuretics may be harmful, and there is no evidence to support in the prevention of AKI. They can be only used as in volume overload, and there is a recent concept of using it as a furosemide challenge test to see if there are enough surviving tubules, when we use furosemide and get a urine output with it. Now, coming to contrast nephropathy, there are various predisposing factors like diabetes, multiple myeloma, cardiac dysfunction, etc. There have been trials over the years with pro and con whether to use. This was a meta-analysis of multiple study, and they suggested that we should use N-acetylcysteine if high dose of contrast is anticipated. However, the most important issue now is if we use iso-osmolar contrast, if you use low osmolar contrast and limit the contrast volume, say less than 20 ml, then we will not have a problem with iodinated contrast. And that's why there are many editorials articles saying that whether iodinated contrast AKI is a myth. Now, coming to the post-operative setting, first thing is to identify the patient at risk, elderly patients with background CKD, multiple comorbidities, infections. Now, these patients may develop AKI post-op. And as I mentioned, we have to be extremely vigilant during the operation that patient does not develop hypotension and does not develop hypervolemia as well with multiple transfusions, etc. And one way of doing it is doing a transesophageal echocardiogram, and which is utilized now in cardiothoracic surgery, but may be useful even in other major surgeries. And other thing is to discontinue drugs like ACE inhibitors or ARBs maybe 24 hours before major surgery, where there is expected major bleeding or volume shifts. Now, limiting progression, various agents have been used, including erythropoietin, which decreases apoptotic activity of cells, but none of them are very promising. So I'll move on straight to management of established ATN. So here also, once ATN is established, we have to be very careful about maintaining the intravascular volume, the cardiac function. And one important aspect is nutrition, because like CKD, we should not restrict protein in these cases. These patients are very catabolic, and we should give protein 1 gram per kg per day and energy of 35 kilocalories per kg to maintain the nutrition. Treat infection, adjust drug dosage every day on the rounds by calculating the GFR. And Ravindra Mehta, one of the critical care nephrologists in USA, he showed that early nephrology referral is beneficial, particularly in ITU. There are many drugs in the pipeline, and hopefully we'll get some preventive agents soon. But now coming to just a little bit about kidney replacement therapy, these are the traditional indications published by Ronco and Bellomo in Kidney International. So refractory oliguria, refractory hyperkalemia, refractory acidemia, and along with that features of azotemia, refractory pulmonary edema, uremic encephalopathy, uremic pericarditis, and neuromyopathy. These are absolute indications for starting kidney replacement therapy. Severe dysnatremia can be managed with renal replacement therapy. We have various modalities at our disposal, that is various types of peritoneal dialysis. intermittent, automated, CFPD, various types of hemodialysis, including SLED, slow, low efficiency dialysis, and various types of continuous renal replacement therapies, which continue for 24 hours. I'll just briefly show you these. Basically, for these renal replacement therapies, we are using two principles. One is diffusion, where urea creatinine diffuses out from the blood, and other is convection, where we run a huge amount of fluid across the semi-permeable membrane, and the toxins are washed out with the fluid. Now, PD can be done in nursing homes and low resource settings where there is no facility for hemodialysis, but it is usually inadequate for uremic and fluid control. There is chance of peritonitis and hyperglycemia. There can be abdominal fluid leaks due to diaphragmatic immobility, difficult to wean off the ventilator. With intermittent hemodialysis, often within 4 hours, if you are trying to ultrafilter too much fluid, there may be hypotension, arrhythmias, variable solute control, cerebral edema due to this fluctuation. So therefore, in these cases, CRRT is preferable. Of course, it needs 24 hours supervision, and patient has to be anticoagulated throughout the day. More expensive, definitely. But in very critically ill patients, where maybe patient needs TPN of 2 to 3 liters per day, for better physiologic outcomes and hemodynamic outcomes, CRRT is better. However, till date, they haven't been able to show mortality benefit. With this, of course, very difficult to carry out trials in this situation. However, there are two absolute indications. There is raised intracranial tension and severe hypotension on multiple vasopressors or after cardiothoracic surgery, where CRRT is absolutely needed. This is slow continuous ultrafiltration, where you can see this is the blood circuit and this is the ultrafiltration happening. We have continuous veno-venous hemodialysis, hemofiltration, where the fluid removed can be replaced per hour by a substitute fluid pre-filter or post-filter. We have continuous veno-venous hemodialysis. It's just like a normal dialysis, where a dialysate fluid is moved in a countercurrent mechanism on the other side. And we have a combination of diffusion and convection, all these modalities, where we can do dialysis and filtration, CVV, HDF. This is the optimal modality, the best modality in cases of septic shock. This is the CRRT machine we have, and they have 4 pumps for controlling the 4 circuits which I showed you. SLED is an alternative now, and it has picked up very well, particularly in low resource countries. It addresses some of the disadvantages of CRRT, but is more economic resource efficient, because we are using the same hemodialysis machine. With the flick of a switch, we can do SLED. In other cases, we can do intermittent hemodialysis. So hospital management definitely likes this, the SLED machines. In future, there has already been development of these portable dialysis machines, and this, with the evolution of nanotechnology, is being further miniaturized, and soon it may be implantable in the abdomen, and we can have something like an insulin pump, something where the patient is getting renal replacement therapy 24 hours a day. So that may be the future of AKI, and along with tubular cell lines within this small machine, which replicates the metabolic functions of the kidney. So to summarize, first of all, early detection of AKI is crucial, as I mentioned, because preventive strategies are the most important and vital things we have. Holistic critical care is key. While managing even other organ systems, we might use kidney-friendly strategies. Monitor and optimize the intravascular volume and renal perfusion. Crystalloids are preferred as the resuscitation fluids. Norepinephrine should be the initial vasopressor. Normal saline along with N-acetylcysteine and isosmolar contrast, I think the way forward to prevent contrast-induced AKI. In critically ill patient, a mixture of diffusion and convection may be necessary when we are producing renal replacement therapy. And finally, the modality of renal replacement therapy needs to be tailored to the unique needs, infrastructure, and economy of an individual ITU and population it caters to. So it is not essential for every hospital or nursing home to have a CRRT machine. And most of the cases can be managed with SLED, and one must only use something where which we are familiar with and we can use it properly. Thank you very much for your attention. Now I will welcome any questions.
Thank you, Arghya, for a very excellent and exhaustive lecture and a nice summary too. So to pick up the pearls, what Arghya had discussed long, so the urine output has been identified as a very, very low cost but sensitive indicator of AKI, which is lot way preventable, as Arghya said. Two important mechanisms, hemodynamic and toxic, and identify those hemodynamic and toxic insults early. And rest management has been excellently summarized by Arghya, and I think that could satisfy the appetite of both clinicians and students. The discussion is open for audience.
Arghya, you can pick up the questions from the chat box. There are some questions at the chat box.
Okay.
So excessive physical activities and AKI asked by Dr. Shubhendu Ghosh, acute cortical necrosis, global and focal as a cause of AKI, and diagnosis of AIN and management. Rest questions I have already answered in chat box.
Okay. Yes, excessive physical activity, that is important. Now, excessive, sometimes, marathon runners and excessive physical, that can cause rhabdomyolysis of muscles and myoglobinuria that can cause AKI. But another thing I've seen 2 or 3 patients, with the recent fad of gymming and having high protein supplements. I've seen, they come alarmed with a high creatinine, say 1.6, 1.5 creatinine. And what I do in these cases, both these cases, I have checked the serum cystatin C, and serum cystatin C is normal because it's not based on muscle mass. And so these patients actually do not have AKI. They have just because of high intake of protein drinks, and the creatinine production is more from the muscles. Second thing is, yes, acute cortical necrosis. This is a devastating condition sometimes faced in various situations like septic shock, or even after eclampsia or postpartum hemorrhage. These situations are faced, and that is a condition where there is no recovery of kidney function even after 6 weeks, and patient goes on to require hemodialysis throughout their lives. So sometimes we do a biopsy. There is no very good test, non-invasive test to diagnose this. There are some indications that MRI scans and things can indicate, but there are no very good tests. And to confirm this, and to ask the patient to prepare a fistula and go for long-term dialysis, we do a kidney biopsy. Now, diagnosis of acute interstitial nephritis. Again, the simple tests like urinary casts are not frequently reported by most of the labs. Eosinophilic casts may be of help because in many of the antibiotic-associated allergic acute interstitial nephritis, these casts are present in the urine. And the important thing about acute interstitial nephritis is it should be picked up early. And if it is picked up early, and if steroids are given, corticosteroid treatment within 1 month, then there can be resolution of the interstitial nephritis. But often we get the patient later, after a month, and at that stage, the patient don't respond to any treatment, and they may go on to develop CKD. So So I think a very important aspect. Other thing is radio contrast, nephropathy. I think that I mentioned that at the moment with use of isoosmolar contrast, that is not too much of a problem. Only during emergency PTCA, or if they do a ventriculogram and use large volume of contrast, say 500 ml contrast, then there is risk of renal injury. But normal saline, yeah, sodium bicarb, there were a lot of agents have been tried. One was alkalinizing the urine with sodium bicarb. Now that has not shown to be effective. Big study published in NEJM. Finally, just normal saline hydration. And like I said, I sometimes in these high risk cases, I do give N-acetylcysteine. And if you give it, it has to be given in the higher dose of 1200 milligram BD, as was shown in the post-PTCA trial.
Arghya, may I give
Yes.
my 1 or 2 line input about
Yes, sure.
cortical necrosis?
Yes.
We get cortical necrosis relatively more frequently because we deal with some acute toxin related AKI like snake bites.
Snake bite.
And important and Praki, as you have mentioned, pregnancy related AKI and thrombotic microangiopathies. Either they're related to Praki or atypical hemolytic uremic syndrome. We find acute cortical necrosis in these three situations, and the important indicator is the requirement of non-resolving AKI. No improvement after 3 to 4 weeks of dialysis dependence. We get either cortical necrosis or patchy cortical necrosis. Some other cause of AKI. Cortical necrosis is actually not a cause of AKI, rather some extreme bad effect of AKI, acute kidney injury. And there was one question I was seeing that diabetic patient with secondary FSGS, we are looking at as a part of a project of 125 diabetic patients with renal dysfunction either or proteinuria. So consecutive 125 patients, 110 patients do have FSGS in their biopsy. So a secondary FSGS is a new entity that has come up, and that has diabetes is one of very, very important cause of that. There are more causes which we may discuss in appropriate platform, but diabetes is an important cause of secondary
obesity and
yes.
So I think we have answered the other question
if there are no questions.
Renal biopsy.
Yeah, maybe close the session if there is no question. Professor Rai?
Yes, I think Professor Banerjee will tell the final words. Dr. Amol Banerjee, please.
There are some questions from Shivendu Ghosh that tropical AKI.
Okay.
There are some
Answered, already answered.
Sir, আমার ফ্লাইটটা এসে গেছে, আমার বেরোতে হবে। আমি তো পাটনাতে অর্ঘদা।
ও আচ্ছা আচ্ছা।
ওকে আইএসওটি তিনটার মিটিং আছি।
ও আইএসওটি তে গেছো, আমি ভার্চুয়ালি জয়েন করব।
Okay.
Yes, tropical.
Any way.
Tropical
AKI. If you think, just a minute, Orpita, if you think you are compelled to just log out for your going to airport, you can do it. And we express a lot of thanks for agreeing and actively sharing this session. On behalf of the ICP and also API West Bengal branch, we express sincere thanks to you.
Thank you, sir. I feel it is my privilege to interact constantly with internal medicine because that enriches me quite a lot.
Thanks.
Thank you, sir. Arghya, with your permission too, I am leaving.
Yes, thank you, Urpita. Thank you.
Argo, there are some questions in the chat box. You look at.
Yes, I'll answer the.
And also, Dr.
One is.
I may ask 1 or 2 questions.
Okay. Now, first, to answer question of tropical AKI. Yeah, in India, we have falciparum malaria, dengue, yes, snake bite, as was mentioned, and copper sulfate poisoning. I showed a few representative studies. It's such a vast topic. I could not go individually into tropical AKI, but very important. These are the causes in Indian population. And another thing is, yes, very importantly mentioned, mismatched blood transfusion, because that causes massive intravascular hemolysis. And the renal tubules are exposed to hemoglobin. And like myoglobin, hemoglobin is also injurious to the tubules, and patient can go into AKI. AKI to start with sometimes continue longer, move to AKD definition area. Patient survives after 3 months, the creatinine may become normal, remain indicating AKI progressing to CKD. Yes, well, that is what we discussed, that AKD is sort of more than 7 days, and after 3 months, if the creatinine is raised or there is proteinuria, then we say that the patient has progressed to CKD. Which category hepatorenal syndrome should be put? Hepatorenal syndrome is a pre-renal azotemia. And idea, as you know, then hepatorenal syndrome, if the kidneys are taken out from the patient and transplanted in another patient, then they function totally normally. So there is no injury actually to the tubules. It's totally a pre-renal situation due to imbalance of the vasoconstrictor and vasodilator. Have you done IgG4 level in retroperitoneal fibrosis? Yes, that's an important cause of retroperitoneal. This patient is a slightly, we dealt with this patient about 5 years ago. At that time, the awareness about IgG4 was not there, but recently, all the other patients of retroperitoneal fibrosis, we do try to do a biopsy and check for IgG4, or at least check the blood levels, which might be of some help. IgG4 is a very important cause of retroperitoneal fibrosis, and we have dealt with a case recently. And that patient was also well managed with immunosuppression. The very important points brought out by Dr. Shivendu Ghosh. Yes, thank you. Any other questions?
Milan, do you like to ask any question?
No, it's okay. It's nicely covered. It's nicely covered everything.
Okay.
Thank you, Dr.
There is no other question or any comments from panelists or anybody else, then our final ritual, that is to give vote of thanks. Whether Sotto Gamuli is here?
No, sir.
If Sotto Gamuli is here, he is supposed to give vote of thanks. If Sotto Gamuli is not here, then I request Dr. Shivendu Ghosh, who is scientific chairperson of API West Bengal branch, to give vote of thanks. Shivendu Ghosh, please.
Unmute karo, unmute karo, unmute karo.
Oh, thank you. Thank you, Dr. Amal Banerjee, chairman of API-ICP West Bengal branch, and also thanking the other panelists of this meeting. I am very much grateful to the very good lecture given by Dr. Arghya Majumdar, and very good chaired by a very important personality of nephrology, Dr. Arpita Rai Chaudhary. And I'm also grateful to the other persons who have attended this meeting and make it a great success. Good number of people are already attended, and I think it's our huge success because of the presence of number of attendees. With these few words, may I stop here and ask the chairperson, Dr. Amal Banerjee sir, to end the session. And I'm grateful to everyone also. Thank you very much.
Thank you, Shivendu.
Thank you
for your kind words. I express on behalf of API West Bengal and ICP my sincere thanks to you all. Next Sunday, we have a very fascinating and important clinical issue.